Hi, my name is Dr. Mark Blatt. I'm Intel's Worldwide Medical Director. We're here today at the Exchange Health IT Summit Conference in Palm Springs. I just got done talking at a workshop on behalf of InterSystems Corporation, and the topic was on collaborative workflows and how mobile tools and Exchange enable collaboration. I actually tried to make 3 points during the summary. I spent a fair amount of time talking about the transformation in payment systems that was going to allow for collaboration so that entities for collaborating would actually get paid and entities that did fee-for-service would gradually diminish. I talked about the need to collaborate beyond firewalls with multiple actors in multiple venues in different settings, and I used a couple of different examples about collaborative workflow, including nurse sign-out at the time of discharge and avoided readmissions by collaborating with EMS services at the point of care. I then talked about how you could use IT technology to develop your own infrastructure to support collaborative workflows. That would involve real-time video communication and streaming telemetry between two providers or a provider and a family, a care member, in a different setting to allow for care to be done by the patient, by the family, wherever it's needed, whenever it's needed. I left the team with a call to action to think about collaborative workflow within their organization and to identify a pain point and a collaborative workflow that would make sense for them, and then look at the IT infrastructure they would need to develop in order to support that collaboration. The 3 main bullets that I talked about were the movement towards value-based healthcare, the move towards collaborative workflows, and the move towards patient empowerment, which will lower costs and improve outcomes. One of the more interesting ones was with emergency services organization in the Shenandoah Valley and a healthcare system called Valley Health, where we actually decided that if we were able to communicate with EMS services in rural areas that were bringing patients in, either to a critical access hospital or to a trauma center, that we would be able to get a better result. By putting 12-lead EKGs into the ambulance and transmitting them back to the trauma center, we could make a better triage decision about where the patient needed to go. And if the patient needed to come to the trauma center, we could activate the cath lab and move them door to balloon time with about a 35% time saving, which translated into more saved heart muscle and better ejection fractions. We discovered by simply doing this technology, by attaching 12 leads to a laptop and then an access point, the solution was usually not as survivable as we wanted. It would work for some period of time and then go down. EMS would become discouraged and wouldn't believe the solution was something they could do in a reliable fashion. So instead we changed the technology. We built a local cloud inside the ambulance. We attached the EKG telemetry to the cloud. We transmitted the cloud back through a high gain antenna on the roof, and we did a lot of virtualization of the services, and we used vPro technology to manage the remote cloud so it was always available, always on, and the connection was maintained to the back-end hospital. So using remote management technology, we made the cloud survivable in ways that a simple access point couldn't deal with. That was one really cool case study. Another one was a study done by the American Academy of Family Physicians, where it looked at citizens that had a patient-centered medical home and those that did not have a usual source of care. It tracked them over almost a decade and looked at what percentage of patients ended up having to access the emergency room for routine care. It turned out that those that had a usual source of care in a patient-centered medical home only used the emergency room about 4% of the time. Those that did not use the emergency room slightly over 20% of the time. That delta alone in trying to avoid emergency room visits for unnecessary care or care that could be better delivered in a lower cost setting is enough to really make a dramatic difference in how we fund care. So right now, a major push is avoided readmissions. I think the next major push is going to be avoided unnecessary ED trips. one of the ways when you actually start to think about collaborative workflows, what I'm really trying to do is get multiple actors in different venues sharing information to have a better outcome for the patient, the citizen. When I say multiple actors, I'm not just referring to doctors. It could be doctors, it could be pharmacists, it could be home care nurses, it could be EMS, it could be a community physician, it could be a social worker, different actors. And by the very nature, as I just labeled those actors, you would realize they're in different locations. They might be in a community health center, they might be in an emergency room, they might be in an ambulance. Okay, so now I want these actors to come together in cyberspace to form ad hoc teams. And there are two technologies that have come into existence that are now easy to do and fairly cost effective that 3 to 5 years ago would have been very hard. The first one is ad hoc video conferencing. In some ways, we all have an ad hoc video conferencing tool in our pocket right now. You call it your smartphone. You can use a variety of different applications which you can download from either Google or from Apple or from Windows, and actually put video conferencing tools on your smartphone, such as you can have a real-time chat. Probably the biggest one that most people have heard of as a consumer service is Skype. So how do you put Skype on a tablet, a computer, or a phone, and then have a inexpensive, if not free, video chat with someone who's not necessarily even in your own country, but could be across the planet? And even senior citizens are becoming exposed to Skype because they've discovered the wonders of being able to chat with their grandchildren and be able to participate in their grandchildren's life. My wife became particularly interested when our daughter moved to Boston and she missed having dinner with her. So they had a couple of Skype dinners together. And my wife felt like my daughter was still part of dinner with us. They actually cooked dinner together on Skype, which I didn't quite understand, but that must be a girl thing. So video conferencing, which is now easy to do, affordable, and people can start to use it. Take that with streaming technology. And what do I mean by streaming? Well, the best example of streaming is Netflix. Here we're streaming a movie. But in order to get that movie to stream to you, I take your Netflix icon and I place it on your end user device, right? You sign up on your tablet. You sign up on your Blu-ray player, your TV, your PC. It doesn't matter. As long as you get that Netflix icon, that container on the device, now I can stream to that protected container. Okay? So now, what if I could stream X-rays, DICOM, information out of a vendor-neutral archive? I could stream your MRI, your CT, your ultrasound. Ultrasound could be especially useful, especially in outpatient settings. What if I could then stream telemetry off a central monitoring station if it was a hospital? There's an application now in all 3 stores called Airstrip that'll allow this to happen. But there are other applications that allow you to stream telemetry beyond that. What if I could get a view of the EMR? So I postulated, what if I had on one tablet DICOM, X-rays, telemetry, the EMR, and now I could set up a video conference. What could a clinician do with those 3 data elements in front of them and assembling an ad hoc team in cyberspace, including maybe the family, your daughter, and other concerned family members? I might be able to do things in 90 seconds, 2-3 minutes, that would have otherwise taken me a half a day, or multiple missed phone calls to do. So streaming, video conferencing, and telemetry, and one of the things we postulated is, what about real-time sign-out at the time of discharge? So imagine a nurse who's discharging you, or a doctor today. They hand you a whole bunch of pieces of paper, a whole bunch of instructions. They ask you to make several different kinds of follow-up appointments and do lots of different tasks. And meanwhile, you're just coming off a bunch of drugs and illness. You're trying to figure out how to get all these potted plants into your car, and is your son going to be able to get here in time to take you home? You're not really listening to anything that the doctor's saying. You get home and you go, what'd they say? Well, what if I could actually do real-time sign-out? What if that doctor or nurse said, where are you going? And you go, I'm going to go visit Dr. Smith on Main Street. They make a quick video call to the nurse in Dr. Smith's office. The 2 nurses do handoff or sign-out, just like they would do at the end of shift. They sign you out to each other. And then the discharge summary, the CCD, whatever the documents are that are relevant, they transfer in real time. So now, tomorrow morning, when you call Dr. Smith's office and say, hey, that blue pill they gave me is making me dizzy, Dr. Smith goes, what blue pill? What'd they do to you? He's got the immediate records, in real time available in his or her office. He knows what the blue pill is, and he doesn't have to say, go back to the hospital, which is what he would say today. He would say, I know what's going on, here's what I think we should do. Huge difference in outcome for you as the citizen, the patient, and huge difference in cost for society. Sure. One of the things we were talking about with patient empowerment during the workshop was the Open Notes project. Open Notes is a project looking at the outcome of patients being able to read the actual raw doctor's notes. Now, many doctors would be concerned if their patients were able to read their notes, that they might not understand them in context, they would get bad information, and there would be a bad outcome, that nothing very much good could come from reading the doctor's notes. So Open Notes decided to look at this thesis and see whether or not it was true. It was a project that was done at Beth Israel Medical Center, Boston, Geisinger Medical Center in Pennsylvania, and Harborview in Seattle. It involved 105 doctors that signed up and over 13,000 patients. What they did at the end of the visit is they sent the patient a note with a URL where they could see the note from the chart. Halfway between the visit, they sent them a follow-up reminder URL, and just before the visit, they did it a third time. What they discovered was about half the patients opened up one of the notes to view the note. And then the outcomes of what happened as a result of that were somewhat surprising. Yes, about 5% or so on average, patients became concerned after reading the notes, became alarmed, didn't understand something. It might have led to some negative outcome. But about 80% of patients felt empowered, became part of the healthcare system, began to understand what their doctor was thinking, and started to become more part of the collaborative care that was going on. 80%. And then maybe the most startling finding, and again, this was an article on Open Notes that appeared in October 2012 Annals of Internal Medicine, the Open Notes outcome study improvement in medication compliance. They didn't explain why, they just said this was an observation. A 70% improvement in med compliance from simply having the patient read your notes. We weren't talking about exotic, expensive, brand new technology, you know, like RFID dissolving pills or bottle pill note reminders or whatever, added cost. This was, we exposed the note. This was virtually free, and we had a 77% uptick in compliance. Amazing. This needs to be looked at further and studied further. Open Notes and patient empowerment has true value.